Please, Dr. Ahmed.
Thank you, Dr. Samir, for the introduction. Good afternoon, good evening, my colleagues. First of all, I'd like to thank Novartis for inviting me for this symposium, and thank for all the attendees who is keen to attend till that time. And it's a deep dive in chronic spontaneous urticaria. I think now we are acknowledging and witnessing that we are seeing these patients nowadays almost on a daily basis, weekly basis. So we have a high reporting of urticaria patients. I think not only because of reporting or the numbers are getting more, but we are now become more experts to identify and diagnose this kind of disease, which was having lots of question marks earlier in terms of diagnosis and also the availability of treatment options. So we'll be having a spotlight in chronic spontaneous urticaria. And as we know, if the lesions in the superficial level, it will be wheals. When it goes to deeper level, it will be an angioedema. Our patients are usually complaining of frequent attacks of itch, wheals that usually disappear within 24 hours. When it comes to the angioedema in the upper lip or in the hands or any other parts in the eyelid, it will can stay up to 72 hours. And usually our patients in this will be complaining more from pain and burning situation, burning sensation rather than itch. And we do see patients having both together, and sometimes we may have even up to 10% of the patient, they may be represented by angioedema alone. If the attacks happened less than 6 weeks, we are talking about acute urticaria. If it's more than 6 weeks, we are talking about chronic urticaria. And when we talking about the chronic urticaria, it's very important to identify trigger, because if you're able to identify trigger, we are talking about chronic inducible urticaria, either talking about physical or the non-physical, dermographism, solar urticaria, cholinergic urticaria, adrenergic urticaria, cold urticaria, pressure urticaria. All these are urticaria which induced by something. If you are able to identify the trigger, we are talking about inducible urticaria. However, most of the cases you will not be able to have a specific cause. In that we have the term of chronic spontaneous urticaria, and I think we have almost talking about 60 up to 90% of the chronic urticaria patients having a chronic spontaneous urticaria. So it's a straightforward diagnosis. Less than 6 weeks is an acute, more than 6 weeks is a chronic. If there is a trigger, we have an inducible. If no trigger, it's a chronic spontaneous urticaria. When it comes to the prevalence, we know that urticaria prevalence can reach to 1.5% of the people worldwide. And I think it's increasing nowadays, not only because of the disease become more common, but as we mentioned that we now will be able to diagnose easily. And females are more unlucky. It's more common in women. And also the average of 20 to 40 years are the average age group. And when it comes to here in the Asian population having the highest percentage of prevalence of urticaria. The important question is the urticaria is a lifelong disease or not? Is this disease can go away in a certain time or not? So we cannot assume that every single patient will be having the disease for life, and we have a hope that the disease may go away in a certain time, because 50% of the cases may go away within just 6 months, and 20% can be still for almost 2 to 3 years. Then we'll be start to have some unlucky patients when can still for 5 years or even can be forever. And the good thing is that only 2 to 3% of the patients that the urticaria can be a lifelong, which basically will resolve within 25 years, which may be the entire life of the patient. So urticaria is a disease, can be chronic, but in half of the patient, it is not a lifelong disease, and it can go away within the first 6 months of treatment. I will not stay time in talking about the disease burden, because I think if you have just to see 1 or 2 of your chronic spontaneous urticaria patients, and you can understand how they are suffering a lot, they cannot sleep well, they cannot wake up well, they cannot work well, all the quality of life aspects will be significantly affected by the urticaria lesion, and I think we are witnessing this in a very regular basis. And when we will see that the patient start to be free from the disease, we will start to acknowledge how the quality of life significantly improving while the symptoms are going away. Because most of the patients, only the disease-free patients who can sleep well and can work well, and all the aspects of the quality of life will be improved gradually. Patients of chronic spontaneous urticaria, they are visiting the hospital more often. They are going to the emergency department more often. And also, they have a significant work impairment, either talking about presentism or absentism, the number of sick leaves, and also the number of days that they are attending the work, but they are not efficiently working because of the symptoms. And I think when you will see your patients, it's very rarely that the patient will not ask for a sick leave, especially when it comes for you with the attacks, especially if the angioedema is also presenting. How to assess the disease severity? It's straightforward. We have the urticaria activity score 7, that you are asking the patients on a daily basis for the last 7 days about the intensity of itch and the number of wheals and hives, and the patient will calculate this on a daily basis to have a score from 0 to 3, the number of hives that happens and the itch severity, and then you have a score from 0 up to 42, and in that time you will be able to identify and assess the disease severity. It's very important because urticaria patient, during the attack, he will forget everything. He will forget the 28 days that he was better, but only they will remember the last 2 days that the urticaria in its peak. So that's why it's very important to have it on a daily basis. So in that time, you will be really knowing how is the disease fluctuation up and down, and that's the way that we can assess the disease severity. The most interesting and important part is the pathophysiology of the disease, and usually we need to understand more and more when we have multiple treatment options. So now the urticaria treatment, I think, is evolving, and we have lots of treatment options in the pipeline. That's why we may need to spend a little more time when it comes to the pathophysiology of the disease. We have 2 major types, the autoallergic and the autoimmune. Autoallergic is a straightforward IgE-mediated. Autoimmune is an IgG-mediated. Make it a bit difficult. Why? Because we have already available treatment option as an anti-IgE. So it's just a normal thinking that if you have an anti-IgE and you have an IgE-mediated disease, that's the easy way to control the disease. However, we're having an anti-IgG mediated disease, which is the autoimmune type. In that time, we'll understand the difficulties that we have it here. And I think when we go to the treatment options, we'll make a deep dive in this part to understand more and more. Guidelines of urticaria is the most simple one because only have 3 lines. Antihistamines, 2 to 4 weeks, up to 4 tablets a day. That's the first line, as simple as that. Then omalizumab in the normal dosage, that's the second line, and add on cyclosporin in the third line. So it's the thing that we can understand and save it and memorize it all the time because it's very simple, only 3 lines, antihistamines, and the most important point here that 2 to 4 weeks is fair enough to say that the patient is not controlled, and then you have the right to jump to the next step, which is add on omalizumab 300 milligram every 4 weeks. And then you may optimize the dose if you don't have an inadequate control, and then you may also add on the third step, which is the cyclosporin. And now even sometimes we are adding on cyclosporin with omalizumab in a low dose, or even you may stop OMA and start on the cyclosporin. That's the guidelines that we have. I think there is one more key player has been approved after these guidelines, which is dupilumab. So I think it is in the same level of omalizumab as a second-line treatment for our patients who are not controlled with a 4-fold dose of antihistamine for 2 to 4 weeks. How to evaluate the treatment success? So the treatment success is evaluated by the UCT, which is urticaria control test, within just 4 questions, answering the last 30 days of the treatment. If you have it less than 12, you need to take an action. Up to 15, you are on the right way, and 16, you may even to think about stop the treatment or withdraw the treatment gradually. What's the treatment option that we have? We mentioned omalizumab as an anti-IgE. It's straightforward, very effective in the patient have an autoallergic type, and as per the data, it's controlling the urticaria activity score 7 significantly compared with the placebo. However, we have a problem with the stopping of treatment that the patient is relapsing. That's a fact we have to acknowledge. Dupilumab, IL-4 and IL-13 has been approved for the patients who are not controlling antihistamine also as a second-line treatment. And again, the urticaria activity score 0 and less than 6 is also impressive because it's significantly higher than the placebo. But what's new? We have lots of treatment options are coming for the chronic spontaneous urticaria and lots of medication in the phase 3 trials. And the most interesting part here is the BTK, the proton kinase tyrosine enzyme, which is in the heart of either the mast cell, the basophil, and the basal cell. And we need to understand what's the role of BTK in developing urticaria, then to understand if we inhibit this enzyme, do we able to stop the disease progression or not? So usually the autoallergic and autoimmune types are IgE mediated and IgG mediated, and they are knocking the door for the mast cell to open. When they knock the door and mast cell open, means the degranulation happen and the histamine release and all these cytokines and all the mediators will start to be secreted and the disease start. So this, after they knock the door, the enzyme which is responsible for this histamine release and the degranulation is the BTK. So if the BTK is working well in that time, whatever the reason of urticaria, either it is autoallergic, autoimmune, IgG, they are already helping the histamine to be secreted. The other thing in the B cell, the BTK is helping the autoimmune mediators to be produced, so also it will be increase the autoimmune antibodies. Also in the basophil, it's also promote the histamine release. So it's a very crucial enzyme in the starting of the disease and also in the progression of the disease. So that's why if we're able to block this proton kinase inhibitor, which is the BTK enzyme, we will be able to stop all this cascade. Whatever who is knocking the door, either an IgE or IgG, either it's autoallergic or autoimmune, so the BTK inhibitor will make the enzyme not working. So in that time, they will not allow the mast cell to be degranulated, so the disease progression will not start. And also, as we mentioned, in the B cell and the basophil, we are reducing the histamine and also are reducing the autoantibody production. So this has been tested by the remoprotinib, which is a highly selective BTK inhibitor, and this has been studied in phase 3 trials, the REMX 1 and 2, comparing the placebo for almost 24 weeks, and then shifted the placebo to remoprotinib arm as an active treatment, and randomized it 2-to-1 for the patient who have a chronic spontaneous urticaria with an endpoint to achieve US7 change at week 12. And also, this has been significantly reported when it comes to the US, the change from the baseline for the US7 came significantly down as early as week 4, and again, with a very high level of decreasing the US7 up to 24 weeks, and the patients who was in placebo shifted to the open label to the remoprotinib, significantly reported US7 reduction. The other pooled analysis, which US7 less than 6, which means that the patient is completely controlled. We can see that significantly, a statistical significance in the first 4 weeks, and then again, a high percentage of improvement, more than 50% of the patient, they achieve the complete control. And again, the fluctuation is almost no fluctuation up to 1 year of the treatment, and even for the patients who was on placebo and shifted to the remoprotinib arm, has been significantly reported, the US7 less than 6. What about 0? No disease activity at all. So again, we have at week 24, almost 40% of the patient. And again, you can see the statistical superiority over the placebo early on in the first 4 weeks. And again, almost flat curve up to 1 year of treatment. And I think it was not easy to talk about US7-0 with the previous treatment options, because this was not even achievable easily. When it comes to the DLQI, if all the symptoms and signs of urticaria came down, significantly the quality of life will be improved with all the treatment options that we have it now. And again, we have also working well in the angioedema. That's the angioedema score of 0. So patients, again, as early as week 4, have significant reporting for angioedema 0. And this has been also reported up to 24 weeks. Also, the patients have a very minimal fluctuation, with almost talking about 80% of the patients at 52 weeks achieved angioedema score of 0. What about safety? Are we going to do an immune suppression or not? Do we have lots of safety signals with the remoprotinib or not? Because BTK looks serious sometimes, but with the high selectivity of the BTK inhibitor, we have almost the same profile as the placebo. So if you see the blue line and the gray line, almost the adverse events are almost very close to each other. We don't have any signal that we need to be worried about. We don't have to do lots of lab tests or monitoring tests before starting the treatment so far. And there is a little bit signal, if you can see here, if you compare the placebo, you'll see that for the influenza, maybe you can see for the pharyngitis, upper respiratory tract infection, which is almost comparable with the placebo, a very little fluctuation has been gone up. So that comes from the point of high selectivity. So I think the future is shiny in treating our urticaria patients, having multiple treatment options. We have injections every 4 weeks. We have injections every 2 weeks. Adding the preferable treatment option of oral tablet can add lots of values for our patients. And I think we start to see numbers which we usually not seen earlier. We start to see a big percentage of urticaria activity score as 0. We start to see angioedema score as 0. We start to see a flat curve with a very minimal fluctuation. And we have a very good safety profile, almost comparable with the placebo. So I think our patients will be lucky when we have multiple treatment options in the future. So with that, I'd like to thank you very much for your attention.
Thank you, Dr. Ahmed. Just one question. Where do you place remibrutinib in the treatment algorithm of chronic spontaneous urticaria?
Okay, so that's a very good practical question, because when we have remibrutinib with us, we'll be having 2 medications available already, which is omalizumab and dupilumab, and then we have the remibrutinib as an oral BTK inhibitor. I think maybe all of them will be in the same level of approval. We don't have data yet. That will be in the same line of approval. But as per the studies that has been run, any chronic spontaneous urticaria patients is defining by the definition of the chronicity and the absence of trigger can be eligible to be treated with remibrutinib, because we have a very fast onset of action. We have a proven efficacy for 52 weeks, and also we have a very comparable safety profile. So I think it will be an ideal for every single patient to have a chronic spontaneous urticaria. And I think also the patients who, because you will see OMA is working very well in the autoallergic type, but the autoimmune type is having a problem. To be able to identify this population before the treatment is a very difficult, but sometimes you are taking the point of measuring the IgE. If you are identifying these patients, you will be very easy to take the decision that this patient can be helpful for remibrutinib. So as a standard treatment of care can be applicable for the patient who is not responding well with UMA, also can be applicable. And also I think that's again can be, you can rely on again for the DUBI profile, because when we'll understand the pathogenesis, you will see that the BTK is really in the center of everything. In all these inflammatory cells, either the mast cell, the basophil, the B cell, but the other molecules, they are not working everywhere. They are working in a specific location. DUBI is reducing the IgE production. It takes very long time to affect the IgG production as well, but here you are blocking everything. Whatever who is knocking at the door, either IgE mediated or IgG mediated. So I think it will be very simple to be as a standard of care for our CSU patients.
Thank you.
Thank you very much.